Okay, welcome everybody. I hope everyone is doing well. My name is Kevin Sabet. I'm the president and CEO of the Foundation for Drug Policy Solutions, and we're very excited to be hosting this webinar here. We have over 265 people registered, so people are just coming on here by the second. But we're going to go ahead and start here. A couple minutes past the hour. Some of us in North America have been looking at or trying not to look directly at the eclipse, but we're in those in the path of totality. I'm not in the path of totality at all, so I'm just stuck indoors. I don't think Amy is either. Anyhow, it's great that we're joined here with just a wonderful panel group of folks. And maybe what I thought we would do is I'll talk for a few minutes about what the UN and the Commission on Narcotic Drugs is, and kind of a little bit of a history. And then we're going to get into what each person here, what they were doing at the CND in Vienna. And then we're going to talk, I do want to talk a little bit about some of the activity that the United States and other countries were doing, as well as kind of a new issue, harm reduction that was brought up, not a new issue to any of you or any of us, but a new issue on the UN floor, at least at the CND, that was brought up, of harm reduction, sort of the resolution that the US had. You might have heard a little bit about that earlier. So the Commission on Narcotics Drugs is essentially the legislative body of the UN of the UN and of the three international treaties that most governments have signed, which essentially lay out some guidelines for international drug policy, including ensuring that drugs remain illegal, although not necessarily criminal offenses, but not legal, and not except for medical and scientific purposes. And so the commission is a functional commission of about 6 countries that are members of the commission, that carry out that work and carry out the work of the treaties, essentially, of implementing them. The UN Office of Drugs and Crime is essentially the executive branch, if we think about it like American government. And for most of us American that are on here, we think about it as the secretariat, as the person that's sort of the group that is also giving direction to countries on this, with the support of research and studies, etc. And then there's this sort of quasi-judicial branch to enforce the conventions, called the International Narcotics Control Board, or INCB. The INCB has a group of a dozen or so people nominated from countries that are members of the commission, and voted on. And so the U.S., our longest serving, I believe, member currently is David Johnson, is the U.S. representative. David Johnson was a longtime international narcotics law enforcement, INL, person. He was an ambassador as well. He was the consular general to Canada and has a history with the U.S. and now serving on the INCB. So essentially, those are the three branches, so to speak, of government, I guess, if you think about it like that. And so this commission meets. The main meeting is in March of every year. And I think combined, the five of us have probably been going for a century, actually, if you think about it. It's kind of scary. I started going in 2002, I believe, or maybe it was 2001, right after, no, it was 2002, it was after 9/11. And it's a very eye-opening experience, but it's mainly for countries and for these countries that are involved. But there are a group of non-governmental organizations that are encouraged to participate. And over the years, thanks to many people on this Zoom, actually, over the years, more and more NGOs have participated. And so Luke and I went wearing the SAM and FDPS hats. And maybe then, Luke, I'll start with you in terms of what we at SAM and FDPS were able to host, and kind of maybe you can take just 2 or 3 minutes, and then we can go around the room about what we hosted and kind of what our activity was this year in 2024.
Yeah. Well, first off, Kevin gave a great, fantastic address to the plenary, to the nations about just the obligations of our treaties regarding scheduling of marijuana as well as other substances. Also referenced the American experience with Oregon and how the decriminalization was, again, another one of those wrong directions to go down that ultimately failed and has been now reversed. So that talk on Tuesday then led into our event on Wednesday, which Sam hosted a side event there on the impacts of marijuana legalization in across the states in America, which was very well attended. Had a lot of people from a lot of different countries there. And then we had another side event from our Foundation for Drug Policy Solutions that did a deep dive into Oregon, looking at all the various outcomes in Oregon and what drove the complete reversal and repeal of their Measure 110, which decriminalized all drugs. So that was another great, well-attended session. And then we co-sponsored with CADCA an event on all of the hemp-derived intoxicants that are plaguing America as well as some other countries, Delta 8, THC 0, these knockoff marijuana products that are being derived from the hemp plant. And so we're able to dive into some of the considerations there in our policy recommendation to close the federal loophole in America, as well as close these loopholes that are being leveraged elsewhere as hemp laws are changed. So that was a little smattering of our involvement. We were also involved in a number of other events and side events, and had a lot of great meetings as well.
Yeah, and a couple, maybe we can dive on into the panel on two of the issues you brought up. The one being the decriminalization of drugs. We're so lucky to have Augusto Noguera here with us from Macau, but an expert in what Portugal was doing and is doing on drug policy. And the Portuguese drug czar we were able to talk to as well. Dr. Joao Goulao was there. And I think Augusto would be helpful if not only you talk about your involvement this year and actually a little bit about your organization, which is doing some really great work, but also about maybe some of the differences between because we have a perception of Portugal drug policy. A lot of people, including myself, had the wrong impression of it when it first came out. Maybe you can talk a little bit about kind of what is happening there on the ground and sort of what you're seeing as well from your vantage point, which obviously is not there, but that would be helpful. And then I also want to talk with the panel, Amy and Stig Eric, especially about the cannabis issue, the marijuana issue, because we did our side event again, which on marijuana, which again, it's always standing room, people flowing out because they're desperate for information about the failures of marijuana legalization in the U.S. and sort of a warning. And I know both of you have a unique perspective on that. Amy is also the chair of the World Federation Against Drugs, which is a fantastic member organization that does a lot of global drug policy developments, along with her hat as the head of the Drug Free America Foundation. And so maybe Amy, after Augusto, you can talk a little bit about the marijuana issue and about kind of what WFAD is also focusing on. And then Stig Eric, given the developments in Germany, but also what's happened in Norway, your own country, and as head of URAD, can talk a little bit about sort of European developments generally, both sort of marijuana maybe and non-marijuana. So Augusto, maybe you can tell us first, kick us off about sort of what your involvement was, a little bit about your organization as well, and then maybe some of these misconceptions about Portugal and Oregon. That would be helpful.
Okay, thank you, Kevin, and thank you for the invitation. Well, starting by my own organization, ARTM, Association of Rehabilitation Drug Abusers of Macau. So it's an NGO, civil society working in Macau, in China. So we've been there since year 2000 as ARTM. Previously, we started in 1993. So in Macau, we work in all the areas. Treatment, prevention, and recovery, and also harm reduction, which now we need to start to change the name for continued care of service, since China did not vote against the use of the word of the harm reduction. But basically, we work in harm reduction as a continued care of service. So we have a needle syringe program, and we also support the methadone. But our main objective is to bring the people motivate them to change their lives, to go into the treatment. So that is the objective. And
let me just, I don't want to interrupt you very quickly, because that is so key. What you just said about what the main objective is, I think that personally, I don't know if you agree, is the central difference between what the drug legalization movement and how they
Yes.
weaponize the term harm reduction.
Yeah.
It's meant for just do whatever you want, and
Yes.
we're not going to really motivate you to do anything. And then in the recovery way to look at harm reduction, which is that it's a means, hopefully a means to an end for certain people, not for everybody, for certain people, to be utilized to go, the end being recovery and a better lifestyle. Sorry to interrupt,
Exactly.
but
Yeah,
that's
sure.
exactly
That's our main objective, and I think, and I, of course, I cannot speak on behalf of China, but as far I know, and through the context afterwards, I have why they did not sign. That was the main issue. It's that the what's going behind the eventually of the harm reduction. They're trying to use that word for eventually for the drug legalization. But that doesn't mean China does not support needle syringe programs or methadone or other services, because as long they're going to the with the objective to help those persons to recover and to refer them to treatment to the health sector. So I think that's why China did not completely sign. But anyway, that's what ARTM what we do, and we try, of course, to help as much as possible. And actually, 61% of the people that they enter in our community treatment community, they came from our harm reduction department, from our needle syringe program. So 61 from them. Our main partner, which is the Social Affairs Bureau in Macau, should be the one that refer the most people to us, is only 4%. So it's obvious when we have a needle syringe program working as a daycare with the psychology counselors, with nurses, with the social workers, and with the monitors, that they are there to help the people, to guide them, to motivate them to go into the treatment. The results they are fantastic. So we don't want to be a needle syringe program as a cold thing that people just there change needles and bye bye. No, we want that place to be a home, a place that they feel comfortable to come and to ask for help, or just to be sit down and meanwhile we are talking to them. Regarding Portugal, I think that's as I'm here in Portugal now, also I help the Arjo Pinhal, and I think they are better than me to speak about what's going on in Portugal. But I think it was very good in terms of reducing the HIV cases, eventually the sharing needles, the less people going to the prison with the minor things, etc. But they forgot something very important. They completely neglect the treatment and prevention on these last 20 years. They disinvest totally. I think I don't want to say it was purposely. Maybe they thought that the harm reduction or that drug recommendation law was the golden key for all the subjects. But now the situation in Portugal, of course, is not like the end of 90s, but it's getting very bad, and is getting some talks on the government level. If they should not start to talk over about changing the law or something like that. But I think the most important was completely the disinvestment that happened in these last 20 years. So basically, a lot of treatment centers they closed down because they didn't have budget for and subsidy from the government for that. Prevention stopped existing, besides small programs from the government, but basically stop. There's few or none civil society working on prevention. People that are working on the treatment center, they have to, and they want to continue working in the treatment center. They have to make agreements with the foreign countries, so to be private, which is it's not affordable for the locals. For Portugal, people they need to pay 3,000, 4,000, 5,000 euros per month. So there's a lot of private sector working with urban councils from Amsterdam and other places. So basically, just for the foreigners. those ones that they are all working on treatment, keeping a faith in working treatment, helping, I mean, they for the last 16 years or 18 years, they just have the same subsidy. So there was no increase of subsidy in the last years. That comes for the closing of the treatment centers, and those ones still working. It's thanks for their determination. So, and that comes to the point that harm reduction can work if we see that as a continuum care of service and alongside prevention and treatment. We need to work all together, and that comes to one of the side events that I was invited to go at the CND was decriminalized drug use and possession for personal use. Why, what, and how? That we said that yes, the decriminalization, as long prevention is still there, as long treatment is still there, and need to work alongside, and as long harm reduction is seen as a point to help the people, and not, as Kevin, you're saying, you do whatever you want, and it's open for everything. And then
we have an American liberty version of when you say decriminalization, which is the do whatever you want. That's sort of and that's actually where culture actually really does matter, right? Because Portugal, and as a country, as a primarily Catholic country, is a country that sort of is culturally against using drugs. So you were able, I think that folks were able to communicate the message that we don't want you to use drugs. We want to, they use this word dissuasion, and in Portuguese, like dissuasão, right? Dissuasion. Like dissuade. Like that's not, we never heard that word used in Oregon ever. We never heard that word used by legalization advocates, never to dissuade. It's always do whatever you want. We're not going to tell you either way. In fact, they're actually saying to do it, even though they're saying not either way, but let alone dissuade. No one's dissuading. And that's also where, Keith Humphreys and others have written about this. The culture differential is so important with policy, I think.
Yeah, and I was in the side event, in one side event. I will not mention names, but I was very astonished when I know the not even drug criminalization as Portugal have currently. These people from the harm reduction do whatever they want. They like that. They don't like that. They don't want. They want completely. Absolutely do whatever you want. So it's not anymore about the harm reduction, how to help the people. It's mainly more, I'm sorry to say, I want to use, let me use, don't disturb me.
Absolutely. No, thank you for that. Really appreciate that. And very interesting point you make too. And again, this is a nuance that is completely lost, that, the intentions were good in the beginning. There was an investment in treatment and what Portugal was doing, an investment in prevention. But for the last, some years now, actually a lot of that investment has gone away. In fact, I'm going to share my screen. Some of you have seen this headline from the Washington Post, once hailed for decriminalizing drugs, Portugal is now having doubts because they're not doing the investment because they're seeing some negative results. You have to, it's the devil's in the details in so many ways. So thank you.
And there's more, even more, because even the harm reduction is not getting subsidy. Just now, some of the providers of the methadone, they need to cut off the afternoon providing the service because they didn't have budget enough to have the monitors and a team to be on the street with a mobile van to provide methadone. So there's a lot of people now in afternoon will suffer consequences because of the current situation of there's no money for the methadone service providers.
Yeah, no, thank you for that. Amy Ronshausen, head of Drug Free America Foundation and World Federation Against Drugs. Take it away.
Okay, so you want me to give a quick overview of?
That'd be great.
Okay. So speaking on behalf for both organizations, like everybody else, we did side events. I think WFAD was involved in 11 or 12 of them, and Drug Free America about 10. Some of them coincided. What we were really excited about was that many of these side events were about recovery, which is something that we're really trying to promote more. And one of them was on the global position paper on recovery, and then another one focused on women and different things in recovery and treatment. So that was really exciting. And then there were several side events that were about youth, that involved youth in doing the presentations, and were about youth's responsibility and policies geared toward youth and how they can impact drug policy themselves. So that was really nice to see in the side event situation. We also had a coordinated exhibit, 2 different ones. WFAD partnered with the Fourth Wave Foundation and So Why, and that was manned by the youth from So Why I Engage and Why They Don't Use Drugs. So it really exemplified that youth voice in drug policy, specifically in prevention. And then the other one, many of you on this call were involved with, and was the We Are All in This Together, which Augusto kind of talked about as well, that, you know, we wanted to really show examples from voices from prevention, treatment, harm reduction, and recovery, and kind of the gold standard in those categories, and really celebrate everything, but really acknowledge that no one arm of us can do this by ourselves. And it really is something working together in that continuum of care that's going to make a difference in the long run. In addition, we hosted a luncheon with WFAD and also the African Union. Stig Erik was a presenter on that as well, and it was a global conversation on marijuana policy. I think we had a little over 20-something member state representatives attend from 20 different countries, so we were really happy about that. And it was just a conversation on the normalization of marijuana use, especially coming out of the US policies, how those policies are marketing toward youth and also women and girls, how that's extending into the European market and even the African market. And then we had a youth on our panel as well who spoke to how these policies impact their daily lives and the choices that they're making, and how she sees that it's influencing her peers. So I thought that that was a really successful session as well. I'm not sure what else to talk about with C&D, only that there was a lot of us there. We were involved in a lot of meetings, and it was really nice to see just a coordinated effort for all of us to, you know, speak in one voice, really showcase prevention, treatment, evidence-based harm reduction, and recovery in a space where we could not only speak with each other on these issues and learn from each other, but also having the opportunity to, you know, meet with and have dialogues with the UN officials and different member states. Now, did you want me to say something about legalization?
I mean, and you could just maybe I mean, you can, or you don't have to. I mean, if you want sort of general, I guess, observations. I do want to get into a conversation in a little bit, so we could also hold it of the Augusto referred to it a little bit, the harm reduction resolution and kind of the influence of the legalization movement. So we can hold on to that if you want. So
yep.
After Stig Erik.
Yep.
Great. Thank you. Stig Erik?
Yes, thank you, Kevin.
And thank you for joining us so late where you are,
no
by the
problem,
way.
No
forced
problem.
Everybody to, yeah.
So I've been coming to Vienna since 2012, and my predecessor at URAD was there several years before that. And I think one of the things that was clear very early on was that the civil society voice was dominated by harm reduction and legalization groups. And we saw it as our mission to counterbalance that impression a little bit, and always promote prevention, treatment, and recovery in the discussions in Vienna. So that's been our mission. In the past couple of years, we've been focusing mostly on recovery, because I think the American debate has handled the legalization issue. So we focused on recovery, and we did a side event on recovery this year too. And we also were involved in a photo exhibit on recovery, which we've been doing for many years. So I think that's our main messages when we come to Vienna. But I think also, for me, it's a great opportunity to listen in on the discussions between the member states, talk to member state representatives, and also talk to civil society colleagues and like-minded colleagues in other countries to learn from their experience and to get a better picture of the drug policy situation on the global level, because this is quite a complicated issue. And whatever is going on in Vienna is also influenced by sort of the macro political issues of the day. It's very evident when it comes to Russia for Europeans and North Americans that the war in Ukraine really is a backdrop to some of the discussions that are going on in Vienna as well. So it's drug policy, but drug policy is part of a bigger picture. So yeah, I think that's my
well, that's a great one, but that's a very good jumping off point. The drug policy and the bigger political picture with the issue one of the issues I wanted to bring up, which was that this issue of the resolution this year. So let me explain this very briefly. So there's kind of two parts to this commission, this meeting. One part is a place where countries come and they give speeches about what they're doing. We gave a speech, many of you did too, about what we're doing, mainly countries, but some NGOs were lucky enough to get in there. And then the other part of the meeting is for countries only. I actually don't think that civil society NGOs are even allowed to speak there. I'm pretty sure they're not. And that's called the Committee on the Whole. And that just means that it's a committee that is working on resolutions, which are not, it's not like legislation. It's not binding laws. It's nothing really about, I mean, sometimes there's a funding note, but no one's like getting money from it or anything like that. You can't give money to special interest groups or anything. It's not like that kind of legislation, but it's resolutions like we have in our Congress. We have a lot of resolutions where it's a declaration of some sort. And then there's sort of it's a way to show that you care about a certain issue. And so every year, some countries put forward a resolution. You don't have to, but the US traditionally every year does it. And I remember when I was part of the ONDCP head of delegation, when I was there before the director would come, we did one on drug to driving, for example. And the one on drug to driving we did, we had to negotiate all this language with these countries behind the scenes, because when you come to present it as a resolution, it's usually looked down upon if there's a lot of division. In other words, you don't like vote on it and it passes by one vote. There's actually something kind of informally called the Vienna Consensus, which means that all the countries vote 100%, in favor of it. Now, if a country has a problem with language, you work on that all week. And we had many nights when we were, in a badly ventilated, hot conference room in the bowels of the UN in Vienna, trying to, work with this country. I remember Australia we had to work with, and there were different reasons why. But anyway, that's kind of what it is. So now Stig-Erik is talking about there's all this political backdrop, with multiple wars going on in the world, first of all, and many other sort of smaller conflicts, and then just general economic wars, you can call them that. And so you have that, and that comes, that doesn't just like go away to just talk about drugs. That's going to be part of this, because the people that are there with the other countries, they're often, yes, they're working on drugs, but many of the people in the delegation, they're working on multiple issues. You can't divorce this from the other political issues they're working on. And so usually you really only bring resolutions where you really think you can find consensus so that you get the Vienna Consensus. The legalization groups that Stig-Erik is talking about, that are more extreme, I'll call extreme harm reduction and legalization groups, their goal is to break, they actually say this very openly. I mean, this is their own wording. They want to break the Vienna Consensus. They want division, so that you have like a 60-40 split of, basically some countries leading the charge on, more legalization type policies, and then other countries, and they would argue more authoritarian, totalitarian countries, sort of being against that. And so you have this division, and then, when your ideas are not the ones implemented, you want there to be division so that you can elevate your ideas because they're not accepted yet. And clearly legalization and this extreme harm reduction is not globally accepted at all. It's actually globally rejected. So they're in the position of wanting to break this Vienna Consensus, okay? And so that's been a long time goal. Let's break the Vienna Consensus. And it's groups like the International Drug Policy Consortium. It's groups like, the Open Society Foundation. There are other groups as well in the UK and beyond. And so what this year, what happened was that the US, many of you know, the US has incorporated the term harm reduction in its work. Harm reduction very specifically defined in the US term. Harm reduction, if you're using that term from a federal point of view, you're talking about syringe services, which is more than needle exchange. Syringe services, you're talking about fentanyl testing strips, which are less accepted, but still part of it. And you're talking about naloxone, the use of reversal medication. And to some extent, medicated assisted treatment, but that's not new. That's been promoted for a long time. But the three things I talked about are sort of the new things, and that's under the American term now rubric, the American government rubric of harm reduction. So the US thought, and I understand, we're going to do a resolution about what we need to do about drugs, and we want to include the term harm reduction. Now, there's never been a resolution with the term harm reduction in Vienna because it's very divisive. I mean, the harm reduction in a lot of countries, it doesn't mean the same thing that Dr. Gupta means when he talks about harm reduction. So it's very divisive, and you can imagine that. And so the legalizers wanted nothing more but for this to happen, and they worked hard behind the scenes, for that term harm reduction. That was really what they were really, aiming at. And so the U.S. put a resolution forward with harm reduction, and they, this was something that again they define as very, very simple. And so there was a lot of work done before CND to make sure how to figure it out. What I'm concerned about is that you had a lot of countries that did not share the same US definition that were trying to piggyback off the US, because actually Augusto said this once and he's right. When the US leads on something, often countries do follow, and this sort of means something. And so a lot of people don't want to necessarily piss off the US. If they want to do something on harm reduction, people kind of want to get on board often. But what happened was you had countries like Colombia. You had some other countries I won't name, but I'll mention that one because they're very open about it, who really were trying to, let's just say, broaden the term harm reduction on this. And depending on how you look at this half glass empty, glass half full, it was either a success or a failure. The original US statement had 8 references to harm reduction, but only 1 was kept in there. Okay, so 7 were actually out there. So that first of all happened. And then secondly, harm reduction was originally apparently in the title of the resolution. That was taken out. Drug checking was removed, apparently. Consumption rooms, so like consumption injection rooms and smoking rooms, was also apparently, I think, in some part of the resolution. I don't think the US put it in there, but in some part that was removed. And so prevention, demand reduction and recovery was actually mentioned more than harm reduction. But very smart legalizers and extreme harm reductionists have taken this and said, we broke the Vienna consensus because China and Russia voted against it. Okay. And there are a lot of reasons probably why they did that, but China and Russia voted against it. And so depending on how you want to look at it, it was a success, failure, whatever, depending on your point of view. But it did make it into a resolution for the first time ever. And the Vienna consensus was broken, I believe, for the first time ever. Stig-Erik might know better than me on that. But at the end of the day, I think when you look at it, I don't think it was that controversial at all, because recovery was mentioned more. Number one. Number two, harm reduction is a very clear definition from the US government. So it wasn't like they were changing policies. But the legalizers really wanted to take advantage of this. And many of the smarter ones, I think, are playing this as this massive victory that they need to now build on. And so, I don't know. I'd love anybody to comment on what I just said. If I got anything wrong, please tell me if I mischaracterized it. But that seems to have been kind of the state of play. And that was kind of the drama that happened, I think, in the committee. But I don't know if anybody else wants to just chime in on any of that.
No, I think I agree, Kevin. From a European perspective, we've always talked about harm reduction for 3 decades at least. So it's not a radical change. I think in a sense, if you want to promote harm reduction, I think that some of the harm reduction plus groups are doing it a disfavor, because they are they're adding some things to harm reduction, which is not necessarily what the countries want to promote, and legalization is of course one of them. Safe supply is another. A drug consumption room is a third issue that they add to this concept of harm reduction, because these harm reduction issues have been on the UN agenda for many years. They've never used the term harm reduction, but they talked about needle and syringe exchange programs. They talked about methadone and Subutex or whatever, medically assisted treatment. So it's the notion of harm reduction is not a new one, but the term harm reduction is new. And I think some of the resistance against the term is because it's ill-defined, and they know that people will take the term and run with it. You see some of the same patterns with decriminalization, which like technically has a very narrow definition, but once the activists get a hold of it, they widen the definition to mean no consequences whatsoever, as Augusto mentioned with so in a sense, on the one hand, I think that you're right that the content of the resolution is not dramatic in any way. I think there is a symbolic issue at hand with the breaking of the Vienna consensus, and I think there is a sort of geopolitical backdrop to this. I think that the Western countries that were behind this were completely comfortable with isolating Russia, and were happy to humiliate Russia on this issue because they knew they knew that Russia would object to this. There's no way that the US would put forward a resolution with so many references to harm reduction without knowing that this is a provocation to Russia and partly to China as well. So they knew what they were doing, and I think that the sort of the geopolitical atmosphere is making it easier to break this consensus. And I think some countries, to some extent, I think there are some countries that have been dragging their heels unnecessarily on some issues. And I think that the challenge of the consensus is, of course, that the most contrarian country will decide the pace, and I think that's one of the frustrations from not just the people who want to legalize, but also anyone who wants to reform drug policy and make it more progressive would feel that it's been difficult to move the drug policy debate forward because we always have to get the slowest one along. So yeah.
Yeah, I agree with Stig and Kevin. I think it's just the harm reduction groups, the extreme ones. I think they've been losing ground in the last years, and they're losing sponsorship as well from their main sponsor. So I think they just these are from United States was like a cherry on the top of the cake for them to try to start to use as a victory of their efforts to show to someone that they've been doing a good job. But in reality, what I think is that the harm reduction and many countries that even they support the drug criminalization, and due to the situations that are happening in Canada, in the US with the fentanyl, they start to see the harm reduction as something already not so. If we're going to legalize this, then we're going to be a chaotic situation even more than we have. So those extreme people, they are smart, they're intelligent, they have a university degree, they are very smart. So they know they have been losing ground, and so that they are using this situation of the breakup consensus as their victory. But in the end, it's like I resumed this resolution on harm reduction as a way of US to support in a more official way the measures of that they're having for many years already there, like the needle syringe program, the methadone, and all that stuff already existing there. They want to start to give a name. So this time they came up with this resolution with this very specific term, and those groups they're just trying to take advantage of that. But if the people understand well, they see that they are a little bit desperate.
Yeah, no, completely agree. And there have been a bunch of questions, and we only have 18 minutes left, but people can feel free to comment and put questions in the Q&A box. We had a bunch of questions about harm reduction and about this. One is a good point that, it's often lost in translation depending on the language, and more than the language, people speaking the same language and saying harm reduction, but meaning very different things, sometimes on purpose, sometimes on accident, right? And so that's an issue. And someone asked about what the three components are when it comes to the ONDCP, and that's syringe services, naloxone, and then drug testing strips like fentanyl testing strips. But yeah, so I mean, look, at the end of the day, is do we want necessarily these terms to be out there? They're already out there. So whether whomever created it, whoever did it, and they're out there. I think the issue is, do we sort of define it the way we want to define it? I don't think anybody wants to not reduce harm. We all want to reduce harm. That wouldn't make any sense. I mean, of course we don't want to increase harm, so you want to reduce it. But as someone also put in, harm elimination, absolutely. I mean, the goal is we don't want to have any harm. That's the goal. The goal of anti-poverty is to have nobody poor. The goal of anti-conflict is to never have war. Right? The goal of anti-racism and it being anti-racist is to never be racist. So those are the goals. Like we want those to be the goals, for sure. But it's just interesting to kind of see how groups, usurp this and kind of take this over. I think another very good point Debbie makes is about the term first of all, the American use of the term, which is very different, again, than let's say like Portugal, but also the use of the term in terms of prevention and pushing a narrative that you can use drugs safely. Because yeah, Ethan Nadelman said, and we have slides on this, that anytime the government uses the term harm reduction, it moves the needle closer to drug legalization and the idea that we can use drugs safely. Right. So, yeah, I mean, that's not what we want, or at least not what I want. And so that is a big problem. And this idea that, this confusion that it brings, and this idea that we can do it safely, just like you can ride a bike, you have to ride a bike. So put a helmet on. That's harm reduction, because you could still fall. We didn't say don't ride a bike. Right. But the idea that to use that on chemicals and on drugs that alter your brain chemistry, I think most of us would think is ludicrous, but that is what's often being mainstreamed here. I'm happy to, I don't know if folks want to answer some of these questions, or if you, Amy, or anyone else wants to chime in, Luke, on any of the things that have been said, or any thoughts, or anybody want to take any of these questions even and just kind of, answer them, please feel free.
Well, I would just agree that we really needed to define that term. And I don't think that the US has done it in our international drug policy thing. We might have some examples, but some of those examples really aren't even harm reduction. I mean, medicated assisted treatment is treatment. It's right in the word. It's really not harm reduction. It should be grouped under treatment. Overdose prevention isn't harm reduction. You still have overdosed. You're just preventing the death, which is great, and 100% for it. We can't have people that are not alive in treatment and recovery, and we need to do that. But I don't think that we as the United States, we as a group of collective drug demand reduction professionals, we just haven't really defined that term so that we have an understanding that our harm reduction stance is something that fits within a continuum of care. And if it doesn't fit within that continuum of care, if it's a standalone policy, and if it's just allowing people to continue on the path that they're at, then that's not something that we could or really should support. And I think that's where the safe use part comes in, is, they say that they're meeting people where they're at, and then just making sure that they can safely use. Well, I think that, yes, we have to meet people where they're at, but we can't just let them linger there. We have to, sometimes hold their hand, make sure that we're really supporting them, that we're showing them the different services that are available, and when they're ready, making sure that they know how to access those services. So I think that collectively, we need to somehow define the term so that we can use it better, even when we're speaking amongst ourselves.
Amy, given your work in prevention and given what you do, Erica Leary, we've worked with her. She does incredible work. She's now with the county of San Diego. is dealing with this issue of how do we keep treatment and recovery principles within a harm reduction, like a local harm reduction program. Is this something that maybe you've seen in Florida? What advice might you give Erica? Because I know there are other people in this situation as well.
Yeah, so I think so I don't have all the exact numbers yet, but a rumor has it that Pinellas County, the county that I live in Florida, is actually going to see a decrease for the first time ever in overdose deaths that are related to opioids and fentanyl. And, you know, we can't put our finger on exactly why that's happening, but we have included a lot of what we would call harm reduction strategies into what we're doing within the county. And a lot of that is based in hospitals. So when people do come in as an overdose in a hospital, that they're not just treating the overdose sometimes multiple times a night with the same patient, but that when that person is revived from their overdose and they're in the hospital, they're being handed off immediately to almost like a caseworker who's going to follow them down this path, whether it be the medical attention that they need, connecting them with a treatment group, connecting them with job opportunities, housing things, food resources, because it's not just about prevention, treatment, and recovery. If your basic needs aren't being met, how can we expect you to make these healthy choices, right? You know, so I think that we've had some success in the hospitals and especially the ERs, and you know, I would call it that, you know, the most urgent care aspect. But even that includes prevention because the whole entire family is involved. And so when you're treating the one person, you're often treating the family because the family wants to know what's happening to their loved one. The family's involved in the ongoing episodes that happen after that. So it also serves as a prevention model, kind of like when we talk about recovery. Recovery isn't just the individual, it's the family, it's the community. And so when you're practicing recovery skills and you're building recovery capital, you're also building prevention capital. And so it all kind of goes hand in hand. Now, I'm not saying that I 100% support all the things that they're doing in this on these harm reduction strategies, because some of them, and I think that these are some words we need to be careful with, and these are some of the words that are in that resolution. They're innovative strategies. Well, when they're innovative strategies, that means they're new. And if they're new, they're not evidence-based. And so we don't have a lot of data and research on how these will work. So there are some things that they're employing that I'm not 100% behind, but I understand why they're doing them. But there have been a lot of things where they have been able to really put harm reduction within that continuum of care and not as an isolated strategy. And I think that that is where we're going to win and where we can make a difference when it comes to preventing these deaths. But also, I think when we look at the opioid issue, we get laser focused on preventing death, and we're not talking about preventing use. So we have to do that as well. So that's where the primary prevention comes into play, and they have to be funded and strategized at equal levels.
Well, and I think we have to really prioritize. You know, I think you're absolutely right, Amy. You hit the nail on the head. There are those who set the goalposts at just keeping people with a pulse, and obviously people have to have a pulse, but that is just a horribly dystopian way to look at the world. Is, oh, we're just going to only care about whether or not people have a pulse. It has to be much more than that. And so I think that's where it's really clear that on the international side, and this is what I'm very grateful to all of you on the Zoom for being able to do over the last few years, is make gains for those who are working with a philosophy of innate human value and empowering people to live fully productive and aspirational lives. And so, you know, that's what the end goal is. And so we know that, you know, it's really interesting. I was just doing a presentation this morning for the Lifesavers Conference here in Denver, Colorado, where I reside. There's a big national conference for highway safety and the roads. And there was a bunch of people from California who did a study, and they showed, they interviewed 4,000 cannabis users, and they asked them all when they started using cannabis. 98% of the people started before the age of 24. And so that jives with the data that we know, all of us working in drug policy know, which is that if you can prevent the initiation of use, before 25, it's very unlikely that people are going to go on and use drugs after 25 if they can get to that number. And so I think, you look at policy, you want to write policies that, positively impact the largest number of people, hopefully at the lowest cost possible, biggest bang for your buck, so to speak. And if we're going to spend so much time talking about niche harm reduction tools that influence a very small number of people, helps them, sure, in some cases, but we're talking very small numbers of people impacted by opioid overdose centers, very small numbers of people impacted by these programs. When you have other programs that are proven, like what you were talking about with primary prevention, treatment and other options, drug courts, some of these other tools that are not fully utilized, that have a much bigger impact on a much larger number of people. And so I think making sure we continue to look at the big picture, where the time and the money really need to be mostly spent, while also including these other things, but understanding that there are pieces of the pie, but not the whole pie, I think is really critical.
Yeah, definitely. And I think some good points that have been made just in terms of the UN and the CND, as Esbjorn Hornberg, who's a wonderful ally. And Esbjorn, if I knew you were free, I would have asked you to you would have been stuck being a panelist here. I didn't know that. But what he was saying, which is very true, is that often country representatives are talking to their domestic political agenda. So when the US is opposing something that Russia's doing, again, a lot of it's like what's happening back home about our war, within Ukraine. When Esbjorn talks about Secretary Blinken, he was there, which was pretty big. He was talking about the opioid crisis for their multilateral, and now I'm forgetting the name, which is terrible. The synthetic coalition that they have, the U.S. is putting together. Colombia probably, why would Colombia be doing this? Well, there's probably a lot domestically involved in Bogota about these issues that are almost much more important to Colombia than whether they take Russia off or not, because they're not really involved in that. So, a lot of this is speaking to other kind of political things. We had just so many good questions and comments, but one thing as we close, I'd like to go around. I will just say very briefly, because Dr. Bunt did ask a very good question about supervised injection centers or overdose prevention centers, or just, whatever you want to call them. There's many names. This was discussed. I know this was discussed in the resolution, but it was so controversial that it wasn't, one mention of it wasn't even allowed to be in there. So still very controversial globally, even though there are versions of this in obviously Vancouver and in Europe and sort of Canada and Europe and maybe some other places, but still extremely controversial from the international level. But again, I think the legalization groups are just happy that this consensus is broken. The US is now on the other side of Russia when it comes to an issue. Normally on drugs, the US and Russia are actually aligned. But now they're on the other side. And so the big question, I think, is, will this carry over to future years or not? Is this going to be now the norm, where there's a more of a, breaking of this consensus and more adversarial kind of environment, which is what the legalizers want. And we definitely don't want that, because we're on the sides of the 3 global conventions, which are one of the most popular global treaties that the UN has ever put out, that stood the test of the last 60 years about why drugs should be illegal. They should be prevented. We should do research, obviously, for medical and scientific purposes, but that countries need to be really working on prevention. I want to end and go around and ask one of the questions that came up a couple times, which is, what does a good drug policy look like? And of course, we could write a dissertation on that. So get the 1 minute of that. And then if you see anywhere in the world that's actually implementing that, I think let our viewers know that. So Stig-Erik, if you want to start us off.
Sure, in 1 minute, no problem. I think the drug policy is a dilemma, and we always have to balance. And I don't think that there is a final solution, a final stable solution here. I think we have to negotiate, and I think we have to balance all the time. But I think that there is no drug policy that can emphasize just one aspect of the policy pie. We can't just focus on prevention. We can't just focus on treatment. We can't just focus on harm reduction. We can't just focus on supply reduction. We need to do all these. And this is like the cliche of all cliches in Vienna, a balanced drug policy. But I think that's the recipe. And I think that I think that some of the drug reform groups are absolutely right, that we need to balance the goals of drug policy with human rights and health issues, and that there a lot of countries have got this balance wrong, and that has been harmful to the drug policy debate. And I think that we are learning, and I think, as I said, but I just don't think I don't think there's a final stable solution that solves the drug issue. I think we can sort of perhaps choose what kind of drug policy, what kind of drug problems we will have, but we can't really choose to have no drug policy problems. So I think that's there is a need for a balanced policy, and I think that's the key. It's not simple, but it's the only way forward.
Amy?
Yeah, loaded question, huh?
Yeah.
I don't think it's something that, I think that we all have to humble ourselves and realize that a lot of the things we're doing are not working. And we have to make sure that we are focusing on the places where we are having successes. But I don't think there's ever going to be a policy that is a one size fits all, only because of this changing drug market. I mean, we see the purity of drugs, the potency of drugs is changing. It's the highest it's ever been. And that means new strategies have to be put in place. As human beings, our culture changes, the way we learn changes, the way we understand things change. And so we have to always make sure that our strategies are addressing those things as well. So I think it's kind of like, when you're building one of those logic models that I just love, that, you think you're finished with it, but it's a never ending document. It's something that always has to be fluid and changing and, kind of really reacting to what's happening. And yes, you want to be proactive, but at the same time, things come up and you have to react to them as well. There are the great thing about C&D and the great thing about these global dialogues is you get to hear from places that you have never been, or sometimes places that you have never heard of, and you get to hear strategies that they're employing and that they're having successes that you can tweak and replicate at home. And I think that that's the beauty of these conversations and these global conferences, is that we can learn from each other. And, as long as in the end, our goal, like Luke said, is to, enable people to live a life beyond their wildest dreams and have healthy, happy communities and families, then, we're unstoppable and we can do all these things. It's just putting our minds together to do it.
Thank you. Augusto?
Well, I agree with Amy and Stig. Maybe something could happen, some magic will be to make the money don't have any value. So if the money have no value, there's no corruption, there's no poverty, there's not many other factors that also that we need to address to have a good drug policy. Because it's not only about, as things say, that we need to work all together. I mean, the good prevention and harm reduction or recovery treatment, but we also need to align with the other factors like the poverty, like the cultural issues, the corruption as well. So all these things that also make our work and to make the drug policy to be effective. And unfortunately, I think maybe in 10 years later, we'll be here talking again, the same subjects. And it will be what we achieve until there, maybe it will be just a little bit a drop, because in the end, the money has all it's the main problem over here. It's the ambitions of the human being, and the things going around in many countries that they survive from cultivating drugs and all that stuff. So it's but I mean, on the field, I think is that we need to work all together to stop with this fighting from one side to the other side. Work all together, build the drug policies balance, but of course also to pay attention to the problems that each country have his own. So is that, I think there's no big solution and never going to happen, but it's try just to minimize as much as we can.
Stig, did you want to say something before I round this out?
Yeah, I just want to jump in and say it's not easy to design the perfect drug policy, but I think there are some things that we should avoid. And I think one of the things is the normalization of drug use, the promotion of drug use, and leaving the drug market in the hands of profit-driven corporations. I think those are a recipe for even worse drug problems in the time to come.
Thank you, Stig, and thank you all for joining us. Yeah, and Kevin, I know you have a couple things you want to say. I just want to thank our panelists for joining us. I know Amy had to leave, but we're going to continue to do the work. I think I don't think you mentioned this at the beginning, Kevin, but we were able to swing the balance of power in the Vienna NGOC. There's more people of kind of the recovery and prevention philosophy that are on the leadership board of the kind of organization of NGOs that are now working in Vienna. So I think we're making inroads, really excited about that. And so I think next year is going to be a good year of getting more of the voice of prevention and recovery and kind of a comprehensive approach. So we'll be looking forward to debriefing with all of you next year as well after that work. So Kevin, why don't you take us away?
Yeah, no, thank you. I want to thank the panelists as well for being here and all of you. I think at the bottom line for us, the way I think about harm reduction, I'm going to be a broken record on this, is, harm reduction can either be a means or it can be an end. And so, it's either a means to an end of recovery or it's just the end of itself. And there was a wonderful comment by Karen Drexler about this, about, what is your metric of success? Is it simply that you sort of maintained this, maintain folks using, or was it that you actually got people into treatment? Was that the goal of whatever that intervention was, whether it be treatment, harm reduction, whatever? So I think that's the key thing. The other thing is, if you all want to be involved in Vienna, please let us know. There's a lot of avenues for NGOs, small and large, to be involved in the discussions that are going on globally. We may not feel immediate impact from them, but I can assure you they do have impact. They impact our political discourses in really every country in the world. And so that's why we're involved. It's why we put so many resources behind it. It's why Amy does, the Garrick Agosto. We obviously have day jobs, but this is very important. It's part and parcel to it. So I want to thank you all for being with us. I hope this was an enjoyable webinar. I hope you learned something. You definitely taught us some things. Great comments and questions. Sorry we couldn't get to each one of them. We will have this available on our YouTube page soon. And I want to just thank everybody and have a good night.